it will take you to a Slido website or app if you've already got it. Okay, is it all right if I start?
I think crack on, Miranda. That'd be grand.
Thank you very much for logging in. Chosen to talk just briefly, informally about Horner syndrome today, which I hope won't be too boring for everyone. So just before I start talking, if you look at that photo, it's just a set of 3 pairs of eyes. And if I go to your Slido, if you clicked on the link, there'll now be a question there as well. Just 4 answers. There are no wrong answers, so even if you don't know, please just pick one. You can't really be wrong with the answers at all. So you've got 3 sets of eyes there, and we're just looking for what's common about them all. And if you can't see the questions or there's any IT problems, please just unmute and shout at me. Okay, great. Yeah, really good answers coming in. Again, there's no wrong answers, so don't worry about what you pick. And I don't know who's choosing what. So you're all getting it right so far. Oh, some people change their mind. Brilliant. There's no wrong answer here, honestly, so don't worry about what you choose. Right. So I think you've all voted, so I'm just going to show you the results. Okay, so the results coming up of the poll?
Yeah,
sorry, Rosie, thank you. Yeah, so yeah, you're all absolutely right. And I will come back to the photo in a minute. All these patients have ptosis. And I know some of these terms, I've deliberately put the terms in just so we start to get used to them. I don't expect people to use these terms all the time. They all have anoscoria, but they all have all the above because they've all got blue eyes. But whoever put all of the above, absolutely right. But every single answer there, you're all absolutely correct. So you all basically now, you all can identify Horner syndrome already. So I'm not teaching you anything you don't know. So that's great. So let's go back to the picture. So, okay. So if you look at this chap in your top left, he's got a really obvious ptosis. So a ptosis is just a drooping off the eyelid. It can be the upper or lower, which is a reverse ptosis when it's the lower, but the most common is your upper eyelid. It's not the same as the droopy eyes we get as we age, and it's not the same as when an eye is swollen and been brought down by gravity edema. I've got a ptosis on my left eye. It's quite subtle. It's from birth. But if you start to look at celebrities and other people, you start to notice people have subtle ptosis. This chap's very pronounced here, so well done if you spotted it in him. This child is also quite, I think, quite fairly obvious. You could miss it, but it is definitely there, so well done if you spotted it. I think this chap here, though, can you see the laser pointer? Rosie, is that visible?
Yes, we can.
Brilliant, thank you. So well done if you spotted it in this chap, because I think yeah, I could have missed it here. It's really, really subtle. You can just see it comes down slightly over the iris compared to his left eye. So fantastic if you spotted that. So anoscoria is just unequal pupils. Really obvious in the child. I think we'd probably all spot this one. I think we'd probably spot it in this chap as well. However, because of this chap's really big droopy eyelid, I think well done if you spotted it on him. He does have unequal pupils, but pretty hard to see. You'd have to pull that lid up to have a good look. So we've got a droopy eyelid ptosis and we've got unequal pupils. But at this stage, we don't really know which, just by looking at the photo, which one is the problematic pupil. So they've all got one big and one small, but we don't know which is the problem. So why did I choose to talk about Horner syndrome is I was reminded of a patient I saw quite a while back. It was a busy Saturday in ED, and I was called a 44-year-old lady who was booked in as an eye problem. She self-presented, and when I called her in, she walked in quite slowly. She was with her elderly mother, and she came in, I introduced myself, and we sat down. She then presented me with, I kid you not, an inch-high stack of A4 lined paper that she'd handwritten. over at least a year or more, a daily log of all her symptoms attributed to her balance issues. So she was under long-term investigation, no known diagnosis for having a lack of balance. She had a diagnosis of fibromyalgia, depression and thyroid disease, but other than that, no other problems. So she told me she was here because she noticed that she had a droopy eyelid. So droopy eyelid is ptosis, which you can see here, and she thought that she had unequal pupils. So when I looked at her, she definitely had a ptosis, and she definitely had on the same side a small pupil. So I thought, oh, I think I know what might be wrong with this lady, as I'd heard about Horner syndrome. So she's got droopy eyelid, ptosis, and she looks like she's got a small pupil, miosis. So on the same side, fairly certain, without much history taking, that I think I know what's wrong. But then I was thrown a little bit because I'd always been taught that it comes in a three. It's a triad: ptosis, meiosis, anhidrosis. Anhidrosis just means without sweating or absence of sweating, and we're just talking about the face area. But she definitely was able to sweat. So I was a bit perplexed. I didn't quite understand why she didn't have all three. So I didn't know you could have a partial Horner syndrome. Now, she wasn't as sweaty as this chap, if you remember from the film Airplane, if you're old enough to remember, but she definitely had the ptosis, she definitely had the meiosis. So I was then a bit perplexed as to why didn't she have the sweating, and what could be causing this. So if we think about what causes Horner syndrome, it's interruption or damage anywhere along the sympathetic nerve supply to the eye. And it will usually, but not always, present as your ptosis, your meiosis and your anhidrosis. And that will all be on the same side, what they call ipsilateral. But anhidrosis is quite difficult to clinically, I think, detect. It's not a very reliable sign. And depending on where the problem on the nerve supply is, it might just be a small dry patch on the forehead, the cheek, the nose. So I think it's really important just to focus on the ptosis and the meiosis. So the sympathetic pathway, the ocular sympathetic pathway, it's really long. It takes a really long circuit route from the brain, from the hypothalamus up to the eye. And it's so long and travels such a precarious path that it's quite vulnerable to damage along that way. So I was trying to work out in my brain what could be causing this lady's Horner syndrome. So she definitely had the pupil constriction. And if you don't know, pupil dilation is innervated, mediated by the sympathetic pathway, but 3 neurons. So really, it's just like a simple road map. It sounds complex, it's not at all. We start up here in the purple route. So you think just like the M25 with branches coming off of it. So in your hypothalamus, and then it takes a really long route and starts descending down the brainstem, and it makes its way down. We're just following this purple route. This is the first order neuron, and it comes right down to the spinal cord. And then round about C8 or somewhere between C8 and T2, it leaves. So then it follows that any damage along that pathway there is going to be due to problems, lesions, masses, any constriction on the nerve somewhere along there. So does anyone want to shout out any problems you might get? Really common things we'd see in A&E to do with the brain that might cause problems with the nerve there. So just think of things, structures in the brain that might press.
If you get a sort of coning or anything like that?
Yeah, no, yeah, I'm sure it could. That I didn't know that one, so that's brilliant. Really obvious ones in the A&E would be your strokes. So if I keep it really simple, I'm sure coning's brilliant. I hadn't thought of that one. But yeah, your CVAs and your brain tumours as well, they can present as Horner syndrome. So moving down the spinal cord. So where it turns to pink now, our M25 route's taken a really odd exit through the cervical vertebra, and it's going to travel up now. So it's coming down and it's travelling up, and that's where it gets really vulnerable to damage, because it arches over the apex of the lung, and then it comes up under your subclavian artery. So if it goes over the apex of the lung, can anyone think of any, and again, we're thinking of big masses, things that are pressing, lesions, anything that might occur. We probably would see in A&E. anything going on in the lung that might cause a Horner syndrome? You won't be wrong, and just shout out anything. It's something we all don't want to miss, particularly in, say, smokers. Coughing, hemoptysis, chest pain, they've smoked for 40 years, 20 a day. Anyone want to shout out what they might be at risk of?
Cancers.
Yeah, brilliant, thank you. So, because it travels over the arch, the apex, sorry, of the lung, it does travel over the arch of the aorta as well. It's these kind of patients, if you've got Horner syndrome and any suspicion of any lung cancers, apex lung tumours, Pancoast tumours can present as a Horner syndrome. So this really vulnerable pathway then travels up the cervical ganglion, and then that's the second order neuron in the pink. So then the one I was interested in with this lady was the third order neuron, so that's in blue on your diagram there. So what happens here is it splits off, and some of the sympathetic fibres, they go off on their A road off the M25 up the external carotid artery, and then the rest go up the internal carotid artery. So at that time I didn't really understand why she could still sweat, but the reason her sweating was grossly preserved is that the fibres for the sweating of the face, they go up the external carotid artery. So therefore, just knowing that she can still sweat on the majority of her face, her lesion had to be somewhere on the internal carotid artery. Because if she had a lung tumour or a problem in the second or first order, she would generally have lost the ability to sweat on her face. So I was armed with knowing that she had partial Horner syndrome, and that obviously at that time I didn't really understand why she was still able to sweat. But all I thought to myself was, well, she's got droopy eyelid, she's got unequal pupils. Is it really a big deal? Do I just need to do an eye referral, or what do I do next? So I tried to work out which pupil was the abnormal pupil. I know this slide looks a bit busy, but honestly, it is a fairly straightforward flowchart, quite easy to follow if you're not used to assessing unequal pupils. So I'd looked at her pupils in the light, they were definitely unequal. The right one appeared to be smaller, that was the one with the droopy eyelid. But what I did next was just didn't turn off the lights, just make it darker. And when you do it, be really quite close to your patient and be looking directly at the eye you think is the problem. Because if it's a Horner syndrome, the constricted pupil will be the problem. If it's a cranial nerve palsy, which can present with ptosis and the third nerve, that will be a problem to constrict. So that will be the opposite, but you just don't know by looking at the patient. So watch the eye. It will be a little bit slow to dilate initially. A normal pupil will just dilate really quickly. But also what you'll notice is the good eye will get really, really big, as it should, and the affected eye will stay small. It will only dilate a little bit. So when I turned off the lights, it was really noticeable. She had a massive left pupil and that really, really small constricted pupil. So I was fairly sure it was all the problem on the right-hand side. So I delved a bit more into her history, and what had happened 2 days prior to these symptoms starting is she'd had a fall, and she said it happens a lot because she gets these unknown balance problems. She was on her landing at home and she just fell from a same level standing. But what happened, she'd not unpacked some brand new bedding, you know, that comes in the hard plastic case, and that was just on the landing, and unluckily she struck the corner of that, or the edge of it, right with the right hand side of her neck. She was a larger lady and her mobility wasn't great. She lived with her elderly mother, so she couldn't get herself up off the floor. So she lay there with her neck on this hard pack for a good, I think from memory, a good couple of hours. So my little light bulb went in my head and I started thinking, oh, I think I might have an idea what's wrong with this lady. So if you go back to your poll, if you're able to, there's a new question on there for you. I'll give you a break from listening to my voice.
Yep, we can see it.
Brilliant. And it's so you've got a patient comes into minors, you click on it, you call the patient in, and because you spotted it now, you've got a droopy eyelid and you think a small pupil or definitely unequal pupils. They tell you they've come off their bicycle. Oh, brilliant, you're all there already. Really good answers coming in. They've come off their bicycle, only about 10 miles an hour, but they have got neck pain. They wore a helmet, they've got no head injury, they've got really sore neck, all on that same side. So you've got 3 choices. You've got carotid artery dissection, you've got lung tumour, or you've got traumatic iritis. So that's where you get damage to the eye and you can get a small pupil. So brilliant, you're all getting the correct answer. So just give you a few more seconds while I just share that screen. Okay. Hopefully, Rosie, is that up for everyone, just the results?
Yep, that is.
Fantastic. Yep, so you're all spot on. You're correctly diagnosed that the most likely cause, obviously they could have the other things as well, but the most likely cause we want to worry about is carotid artery dissection. So that's brilliant, thank you. Right, we'll get you back to the screen. Okay, so then at that point I thought, yeah, this is a big deal. I do need to do something for my patient. So I went off to the consultant, gave a brief handover, and quite sheepishly asked if I could have a CT angio of the carotids for my 44-year-old lady with a painful Horner syndrome. At that point, I was told that we would do a D-dimer and we would get a chest X-ray for this lady. So just to go back, this lady was never a smoker, no passive smoking, no risk factors for cancer, lung cancer. She had no signs or symptoms suggestive of lung cancer. So if anyone just wants to shout out, do they think chest X-ray would be helpful for this lady with her painful neck and her Horner syndrome? Don't leave me hanging, just shout out if you think, yeah, I should have done it, I shouldn't do it. Anyone think it might have been useful? No.
Seems unlikely. Also seems quite a standard answer to get.
Yeah, and I guess I don't forget. So for me, going to it was a long time ago as well. I'm very much, somebody tells me to do something. Even though this case gave me a lot of confidence, I just thought, oh, should I don't know what to do. So yeah, no, I totally agree. Thank you for saying that. Is quite a stock answer. Not really, David saying in the chat. So I went off, sat in my computer and just mulled it over in my head. Because I was I don't know much, but eyes I do like, and I was fairly certain that a painful Horner syndrome with the neck should always get imaging. It's a carotid artery dissection until proven otherwise. It's what I'd always been taught. But I can't order the CT angio. It's a lot of radiation. So I sat there mulling over, and it was a busy Saturday, but I rang the on-call ophthalmologist at home. It was quite some time ago, and luckily it was a very friendly ophthalmologist that I knew her quite well. I said, I don't want to refer to you because that always helps. Just want your support and advice. And as soon as I said a painful Horner syndrome with recent minor neck trauma, and it's acute, she said the patient needs a CT angio and it's a carotid artery dissection until proven otherwise. So I thought, yeah, it is a big deal. I need to act in the best interest of my patient. I don't think a D-dimer will help, and I think a chest X-ray is going to delay diagnosis in this patient. So I went back, consultant very helpful. I told them what the ophthalmologist said, and they ordered it, no problem. Had to speak to Medica at that time to get permission. It is a lot of radiation. It won't be suitable for pregnant women, but for in this case, in this 44-year-old lady, the benefits of diagnosing a dissection outweigh the risk of the radiation. I will touch on later the other imaging at the very end. If anyone's got any thoughts, please let me know. So you all got it right. The last question, it's brilliant. It's definitely consider carotid artery dissection. Now, if you go back to your poll, you should have now a word cloud where you can just type in a word. Any problems you can't see it, please shout out and let me know. And we've touched briefly on a couple of conditions, but if anyone knows any other causes of Horner syndrome, or if you don't know, I've left a list up there for you. Just put anything in there that you think might cause Horner syndrome. We've already said about lung tumours, we said about carotid artery dissections, you can put those in. You can put anything you like, you can. Stroke, brilliant, idiopathic. Yeah, that's really good, the idiopathic. I think do a whole new session on that, whoever put that.
Is that actually one? I was literally just a guess. I assume there must be one that no one knows quite what causes it.
I think you're right, Malcolm, there are, but I wonder if there's like rare things like Eagle syndrome, really rare conditions, and I only know because I did an essay on it, I've never heard of it before. I wonder if we think they're idiopathic, but actually there is a cause there. It's just so rare, it's never found. I will try and find out and get back to you.
Could a pneumothorax or a hemothorax?
Oh, that's really good. I'd open that up to everyone else. I guess so. I guess if it's big enough, maybe more pneumothorax. Somebody else might help me out here. Trauma's not my thing. I'm just thinking hemothorax, because you want pressure up in the apex of the lung. So yeah. Anything there that is causing pressure, I guess could. Yeah, it's not one that's really good. Definitely trauma. So you're absolutely right. Trauma around the area. So yeah, I imagine it must do. I'll find out definite for you. But yeah, that's a brilliant one, Rosie. Stick that on the word cloud for me. Oh yeah, spinal trauma. That's brilliant. Spinal trauma and spinal surgery, definitely one to consider. Lesion mass on brains. Yeah. Right, I'll leave that open and I'll just quickly, sorry, I just realised you can't see that. I'll very quickly share that. Sorry if I'm a bit slow with sharing the screen. I'm just kind of getting used to it.
You're not. This is fantastic.
Right, so Horner syndrome. Okay, can you hopefully see all the answers you gave? Idiopathic, spinal trauma, pneumothorax, stroke, lesion, mass on brain. So they're all there. That's brilliant. And then if I get you back to this slide, it would just show you quite an alarming amount of conditions that can be caused by Horner syndrome. And the reason, if you think about, is it a big deal? Yeah, I'd say it is, because for my lady, the report came back that she did indeed have an internal carotid artery dissection. And I think it is important to know about it, because in internal carotid artery dissection, although there's lots of potential causes, Horner syndrome, with or without pain, could actually be the only presenting problem. And a patient won't always know they've got a droopy eyelid and a small pupil. So I think it's up to us to just make sure we assess that properly.
Miranda, can I just clarify, when you're saying it's with pain, do you mean is there pain in the eye or it's accompanied by painful trauma?
No, that's really good, and I should have elaborated on that. Thank you. So it can be, generally it's neck pain. It just depends where the problem is. Obviously, if it's a first order neuron and the cause is a stroke or brain tumour, you're thinking of headaches, but it's all hemifacial, neck area, apex of the chest as well. So it's all following the course of that path. You can get a painful eye, but it's not really that common. If it can affect the retina of the eye, but you usually won't get it with a painful eye. So not completely to rule it out, but very subtle neck pain is your most common due to the dissection of the artery there. Headaches if it's due to traumas, chest pain if it's due to a lung trauma, but we're only talking about the apex of the lung. So I don't want to say no, you can't get a painful eye, but really the eyeball itself, you won't get a lot of eye symptoms. These patients from internal carotid artery dissections and Horner's, they'll have really good visual acuity. They won't have RAPD, for example. They'll have, apparently they can get a red eye. I've never seen it, but it's generally you're thinking of headaches, facial pain and neck pain. Don't forget about eye pain, but if we focus on neck and face, but really good question, I should have covered that.
So the pain is from the cause, the root, as opposed to where it ends up.
Yeah, absolutely. But you're right, you can get eye pain because the blood supply comes through the carotid arteries to the orbit as well. So if there's a big dissection there and not very good blood supply, you'll get retinal problems and then you could get eye pain. So you're absolutely right. Do consider it, but often that will be a later sign and it won't be the most common one. So that's a great question, thank you. So yeah, if you take away nothing else, I'm really grateful that you all logged in. I've got 4 minutes left. If you take nothing else, if you didn't know before, but it sounds like you all got the answers right that you did. Sudden onset, painful Horner syndrome. So your ptosis, your meiosis, possibly loss of sweating. So your droopy eyelid, your small pupil, and with or without sweating of the face. That is a carotid artery dissection if it's got painful neck or face, until you get imaging to tell you otherwise. So for my lady, it was the weekend in the emergency department. We could really only get a CT angiogram. It was readily available, it was quick. If it was in the week and you could get magnetic resonance angiography, that would be ideal. CT angiography can often miss, because of the bone interference, it might miss intracranial dissections of the carotid artery. Luckily, my lady, well, luckily for picking up, she had an extracranial, so that's why I had to refer to St George's, but they were quite happy that she could be managed by our stroke team. I'm sorry if I didn't cover that, so I had to do an eye refer to St George's. Lovely neuro reg said, no problem, your stroke team can manage it. It's extracranial. We're happy with the location. And she was started on clopidogrel and discharged home after about 8 hours. But yeah, the gold standard is conventional angiography, where they go direct into the vessel, but that can cause trauma and dissection. So realistically, if you get painful Horner syndrome, you're in the A&E and it's the weekend, CT angio is the minimum. If it's the weekday and you're lucky and you can get MR angiography, that's even better. So you may have to sort of speak up for your patient. When I spoke to it was a long time ago. When I spoke to the consultant, they weren't aware that internal carotid artery dissection was a cause of it, of Horner syndrome. Hence why I suggested a chest X-ray. Is familiar with Pancoast tumours. So hopefully helpful mnemonic. Just ptosis, PAM, ptosis, anhidrosis, meiosis, droopy eyelid, which I've got one on this side, loss of sweating, and small pupil. I think you've asked a couple of good questions already, and I know you're probably busy, want to get on with your day, but has anyone got any burning questions?
I've got 2 questions.
Okay.
Right from the beginning.
Supposed to be no, Malcolm. No.
Right from the beginning, I'm afraid. Literally the first slide with regard to the different ptosis that you showed us.
Oh yeah.
This might be a really stupid question. I just didn't get. Obviously, the one on the top left was really obvious. I didn't at all get what we were seeing in the other 2.
Okay.
How are we defining that? What is a ptosis? Would you mind pointing out, or what we're looking for in the more subtle ones?
Because it can be really subtle.
Was it bilateral in those ones or not?
I will bring it. I'll just make sure. Is this the slide you mean? Yeah. No, I should have gone through this. So, got the laser pointer. This first chap. So we look at his left eye. You can see we're looking at the upper portion, how much of the iris you can see. You can see compared to this one, it's really droopy. It's covering almost 50% of his iris. It's coming down. Is in that picture, is it clear that it's just
that one's totally obvious. The other 2, I
totally agree.
They just look like eyes to me.
No, and that's why I threw them in, because I think the fact that people got this one, I'm really impressed. I think I would have missed it in this patient, and I've got a ptosis myself. This is a child, so you can get a lot of congenital ptosis, which I have really subtle, but when you see me next time, just have a look at my eyes, Malcolm. So on this patient, on the patient's right eye, so left, the one I'm highlighting as we look at it, the patient's right eye, if you just follow the upper eyelid, the margins here where the laser is, and then you move over to the left, it is really difficult in this patient, I completely agree, and it's made worse because it's got the constricted pupil. So it alters your perception of looking at it. You can, if you really need to, you could use like the disposable tape measures, maybe not on a child, and just hold it in front, and you're just measuring, the fancy name is the palpebral aperture, and all that is the distance between the lids here, so the palpebra conjunctiva. So here where the lid is on the lower lid, you just measure that height there, and just from there to there. So it's really subtle on this patient, and I'd be quite impressed if somebody noticed it in that child. So that's not a silly question at all. This one I think is really kind of almost impossible to say it definitely is, but again, if you just look, you can just see the top of his iris where the laser is, almost to the edge of the limbus, but in the limbus is just where the iris, the coloured part, meets the white part, and this is just very subtle. And sadly, with ptosis in carotid artery, you can just get a very subtle ptosis, so you really do have to stare at your patient. Ask the patient to look in the mirror. People generally know if there's a change in their eyes. If they've got any old photos that you could look at on their phone, perhaps. But it's not a silly question at all. They don't all present as obvious as this chap in the first photo. This one, I think you could miss that easily, and that wouldn't be a problem, because what you wouldn't miss, I think, is the unequal pupils. You would know that there is an issue with those eyes. Does that help a bit, Malcolm, or should I cover it in a bit more detail?
Yeah, no, that is absolutely
sure. But when I see you next,
yeah, no, that's totally fine. I was comparing to the pupils themselves as the landmark themselves, rather than iris or
that out.
But no, now that you point it out, I can totally see exactly what you're saying.
It's so hard to ignore the pupil, because that makes it sort of the perception it looks bigger or smaller.
Yeah.
So. Yeah. Hope that makes sense.
Yeah, totally. And I've got one more question, I'm afraid.
Yeah, don't worry. Don't worry.
The anhidrosis.
Yeah.
How do you assess for that?
Yeah.
Do you put them on a treadmill? Do you ask them? Is there some test you can do?
Yeah. So so it was new to me at the time. I didn't know you could have it without it. And I did, when I was doing my essay, I did look at, I probably should have included it in the slides, but I was quite unclear myself, because to be honest, it seems like there's no science to it. Some people talk about even using like a Bic biro and the edge. I think people do that on fingers as well, and the touching and whether there's friction. So I did read up on the different tests, but the outcome was really none of them are good enough. They're very crude tests. So I know that doesn't really help you to look at it, but I would say in a way almost ignore the sweating, unless the patient obviously says, gosh, my face is so dry, and they've got something really obvious called a Harlequin sign. So that would be one. Can you also see me on the camera? I'm just sorry, I'm doing all this sign language here.
At the bottom of the screen.
So half a face will be red, very flushed, but in a Harlequin sign, the other side is not, it's just white and it's very dry. So you're right, unless somebody's on the treadmill, I don't think you can easily assess for sweating off the face in the A&E. And the things I've read seem very crude tests on how you do. If anyone else knows some good tests, please let me know. Personally, I just think I wouldn't bother checking for it unless the patient themselves mentions something. Because even, a little caveat is, even though I've said my patient had no sweating, because the fibres, if you remember, they go out the external carotid artery. That's why she could still sweat. There are a few sweat fibres that go in the internal carotid artery and go to a very small part of the face, which I'm just trying to remember which part it is. I think it's somewhere on the cheek or the forehead. I will double check for you. So I think it's an unreliable sign. Apart from checking if there's friction or no friction, is the other side of the face flush or sweaty? I don't personally know how to assess safely for it, Malcolm, sorry. But I would say ignore it. I wouldn't worry about it at all. If you've got droopy eyelid and a small pupil, or even if you're not sure if it's small, just unequal pupils, consider that a partial Horner syndrome.
Cool. Has anyone else got any questions for Miranda? I thought that was incredible, actually, and I had no idea that it went so far down, you know, to the base of the cervical spine and the top of the thoracic spine. I think that is very significant to know. And as you say, then going around the apex of the lung, and it just really gives sort of different causes can have that the same, you know, presenting the same problem. One of my questions to you was, because of that, is there different pathways for treatment? So your patient went, you know, you spoke with George's neurology, and that would make, well, yeah, I mean, neurology, if the problem is up here and maybe here, but if the problem was in the lung, would that go to neurology, or would that go, is the pathway the same?
Yeah, no, it's a really good question. So I suppose my knowledge only, if I'm honest, is around the third order neurons. But if you, so say you picked up, your patient was a smoker, they've come in, they've noticed a droopy eyelid, but then you find out, yeah, I've been coughing for weeks, had a little bit of blood, I've lost a bit of weight. That's when, you know, you are going to do your chest X-ray, your chest CT, and I mean, I think also it means, you know, don't rule out any problems above that as well. People can have two things. I think just because we found the lung tumour, we won't ignore that they could also have something else going on. But yeah, no, if it's first, second or third, the treatment will depend on the cause, if you can find the cause. But yeah, second order will be things like your lung tumours, as you mentioned, your pneumothorax, so that's going to be a traumatic treatment. Your lung tumours, I'm guessing, I don't deal with them in A&E, that if they're very unwell, they go to medics. Otherwise, they get referred to oncology and respiratory. I mentioned, if you remember the second order one, I'm just trying to think of different causes, goes up the under the subclavian artery. And you can, what I didn't consider, but in hindsight, when I wrote the essay, my lady had thyroid disease, and I guess, I mean, luckily we did find a cause, but she could have had, there was no symptoms, but she could have had a thyroid tumour that compressed on that artery as well. So trauma, and sometimes I think, and maybe Malcolm or I think David's on, any ACPs help me out, or anyone, or Katie, putting in chest tubes, chest drains. I believe thoracic surgery can cause the second order, and I think that's quite, you know, a fairly easy thing to damage. So, and then so strokes and tumours were the first one. So we know, you know, even I probably know how to manage a stroke. We would manage it in-house. The reason for St George's is the consultant told me to send that referral. At that point, I just had a diagnosis and I didn't really know then how to manage that. But it's very easy, straightforward management for my patient. It was just clopidogrel and home with a follow-up in, I think, 4 to 6 months to repeat, see how the dissection was doing. But it's really important because, sorry if I didn't mention it, although it's a small percentage of strokes, the literature says sort of 2 to 3%. The reason it's a big deal is if patients under the age of 45 get an internal carotid artery dissection, so even I just fall into that bracket, we huge risk of, much higher risk of stroke. Most of the literature agrees it's up to 25%. So that's why I think it's so important. And then just trying to think, oh, the other one is, well, spinal cord trauma and surgery can be, so if something goes wrong in spinal surgery, I'm hoping they would know how to manage that. But yeah, each of you think, split into 1, 2 and 3. If you find your cause, well, I don't know how to manage all those things, but yes, the treatments are slightly different. And
is it something that resolves once treatment?
Yes.
Okay.
They can do really well. I've seen, so this was quite a few years ago, I saw this patient, but I had seen it before in my other trust. But I became aware then that actually even the consultant, really intelligent consultant, not everyone knew that it was a potential cause, the carotid artery dissection. So that's what I focused on. And I've seen subsequently, and been quite interested in patients, I've just realised the time, if anyone wants to log out, sorry, please, I won't be offended, just go. Patients come in and they happen to have a droopy eyelid, and just out of interest, and they've come in with a sprained ankle, and I asked them, and honestly, anecdotally, I've seen a ridiculous amount of patients that have had Horner syndrome due to a carotid artery dissection, and in most of them, it was a very delayed diagnosis. And if we delay diagnosis after trauma or acute symptoms more than 2 weeks, that patient is very likely going to have a stroke. They could have it minutes after a dissection, but most of the literature gives them up to 2 weeks, and they will have a stroke. Yeah. So sorry for the time. Look, it's 20 to 12.
It's fantastic.
You guys need to go and enjoy your day.
I'll stop the recording there, and if I can, there we go.